Very good afternoon from India. I'm Dr. Preeti Srivastava. I'm consultant pediatrician and pediatric neurologist in a small city called Jamshedpur from Eastern India. So today I'm going to present a very interesting and rare neurological disorder in an Indian child. My presentation is titled PYCR2 mutation causing hypomyelination and microcephaly in an Indian child. The consent of parents have been taken to show the images of the child for academic interest, and there is no conflict of interest here. So myelination is a finely regulated process that involves interaction between oligodendrocytes, axons, astrocytes, and microglia. Leukodystrophy is a heterogeneous group of disorders that affect normal myelination in the brain white matter. And hypomyelinating leukodystrophies are characterized by primarily lack of myelin deposition. Characteristic MRI findings and typical clinical presentations in the form of mostly motor dysfunction with variable cognitive and language impairment is seen in these leukodystrophies. Genetic mutations causing these hypomyelination syndromes are being increasingly recognized. Microcephaly is defined as head circumference less than 3 standard deviation or z-score less than -3. Microcephaly may be observed in 0.1% of the general asymptomatic population, but its prevalence is around 15 to 20% in children with developmental delay. The etiologic spectrum of microcephaly can be wide, ranging from hypoxic ischemic injuries, in utero infections, post-infective sequelae and structural abnormalities, to less common causes like hypomyelinating, metabolic, or genetic disorders. So with this background, I would like to present the case of a 3-year-old boy who presented to us with complaints of not achieving developmental milestones as per age and failure to gain weight. There was some concerns of neuroregression, according to parents, as they said that the child had lost the ability to sit without support, which he was doing earlier. Although he had attained that milestone also late, and now it was more concerning that he had lost this milestone. The child could not sit or stand independently and was completely dependent on the caregiver for all activities of daily living. There was no history of seizures, and other associated problems were difficulty in feeding the child, as he had frequent vomiting and suffered from chronic constipation. Coming to the birth and the family history, the child was born of non-consanguineous marriage. It was a term baby born by normal vaginal delivery with face presentation. His birth weight was 2.75 kg. He cried immediately after birth, and there was no history of an ICU admission. There were no antenatal or perinatal issues. There was no history of any neurological illness in the family, and the patient had an older 6-year-old female sibling who was well and normal. On physical examination, it was seen that the child looked severely malnourished, with his anthropometry showing current weight of 5.7 kg at 3 years of age. If we look at the weight sequence, at birth he was 2.75 kg, which is normal. Then at 9 months, he was 4.6 kg, showing a very poor growth. And again at 22 months, he was 6.2 kg. With the current weight of 5.7 kg. So all these weights were below the third Z-score, showing severe underweight. The head circumference, on the other hand, was not recorded at the time of birth, but at 9 months, it was noted to be of 39 centimeter, at 11 months, 40.5 centimeter, and again, currently at 3 years of age, it was 42 centimeter, again less than third Z-score, showing severe microcephaly. So here are the picture of the child showing severe wasting and his malnourished appearance. You can see the ribs are visible. There is significant wasting, and both his hands are fisted, showing a degree of spasticity also. He had dysmorphic facies in the form of triangular face, prominent eyebrow and lashes, bulbous nose tip, thin vermilion of the upper lip, prominent ears, mouth was always open, although there was no fasciculations noted in the tongue. On neurological examination, it was seen that the child had axial hypotonia with partial head lag and appendicular hypotonia. He had upper motor neuron type of weakness, which with spasticity of all limbs. Deep tendon reflexes were brisk, and the plantar reflex was bilaterally extensor. The range of motion at the hips and knees was child's motor function was classified as GMFCS level 5, meaning he was totally limited in the ability to maintain anti-gravity head and trunk posture and control of leg and arm movements. On fundoscopy, it was normal, extraocular movements were full, pupils were equally reactive, and no facial asymmetry was noted. Other systems were within normal limit. On investigations, and the basic blood test showed a normal profile of complete blood count, liver function test, renal function test, thyroid profile, serum calcium, plasma ammonia, and lactate. They were all in the normal range. Test for inborn error of metabolism in the form of blood, tandem mass spectrometry, and urine gas chromatography mass spectrometry, GCMS, were also normal. EEG and BERA planned, but the parents refused for these tests. The MRI, one MRI was done at 9 months of age, and that was reviewed by us. And the MRI scans showed at 9 months of age significant hypomyelination of deep and subcortical white matter, including the U fibers appearing hyperintense in T2 weighted images. The hypomyelination can be seen by the black arrows. And also the corpus callosum in the adjacent image can be seen in the sagittal section. The corpus callosum appeared thin. Bilateral internal capsules showed normal myelination for age. Cortical sulci, including the sylvian fissures, was diffusely prominent with dilated extraxial spaces, suggesting cerebral atrophy. Brainstem, cerebellum, and deep gray matter nuclei were normal. So to summarize, we had a 3-year-old child with global developmental delay, progressive microcephaly, dysmorphic facies, failure to thrive, upper motor neuron type of motor signs, and hypomyelination on MRI. So a possibility of hypomyelinating disorder was suspected, and for that to confirm the suspicion, genetic test was offered to the parents and they agreed for it. So a clinical exome sequencing was done and it revealed compound heterozygous mutation. There was a heterozygous missense variation in the exon 4 and another heterozygous start loss variation in exon 1 of PYCR2 gene and chromosome 1. So when we put together the genetic test reflecting the PYCR2 mutation with the clinical presentation of the phenotype, it matched. And so a diagnosis of PYCR2 related hypomyelination syndrome was made. The parents were explained about the diagnosis, course, and progression of the disorder, and the poor outcome was explained to them. The patient was given pharmacotherapy for spasticity, and physiotherapy and occupational therapy were recommended. In view of the severe wasting and feeding difficulties, a PEG tube feeding was recommended, but the parents were not keen on it. Now coming to a brief discussion on hypomyelinating leukodystrophy 10. So hypomyelinating leukodystrophy are heritable disorders of myelin formation. The classic prototype is the Pelizaeus-Merzbacher disease caused by the PLP1 gene mutation. Certain other genes have been identified causing hypomyelinating leukodystrophy, and some of them are TUB4A causing HLD6, POLR3A causing HLD7, POLR3K causing HLD21, then PMEM106B, AIMP2, DEGSI, SOX10, etc. So many mutations have been identified related to hypomyelinating leukodystrophy. The PYCR2 gene mutation associated HLD10 was identified for the first time in 2015 by Nakayama et al. So the pathophysiology involves that proline, which is a non-essential amino acid, is involved in the protein biosynthesis and antioxidant reactions. It is synthesized endogenously from glutamate via pyrroline 5-carboxylate synthetase, which converts glutamate to pyrroline 5-carboxylate. Now, this pyrroline 5-carboxylate can be converted to proline by one of the 3 paralogs in mammals called PYCR1, PYCR2, and PYCRL. Defects of proline synthesis have major deleterious effect on the health, leading to intellectual disability, skin and joint hyperelasticity, osteopenia, and cataracts. The clinical and molecular phenotype of the of these disorders of protein synthesis is currently under intensive investigation. To date, mutations only in PYCR1 and PYCR2 have been associated with human diseases, while that with PYCRL has not been associated with human diseases. Homozygous mutations in PYCR1 were reported in families presenting with cutis laxa and progeroid features. However, mutations in PYCR2 were reported in consanguineous families with microcephaly and cerebral hypomyelination. The PYCR2-related disorder has been classified as hypomyelinating leukodystrophy 10, HLD10. So this illustration just shows the conversion of glutamate to pyrroline 5-carboxylate and then thereafter to proline, and the role of P5CS, PYCR1, and PYCR2 enzymes. So it is seen that mutation in the genes encoding for these enzymes may lead to certain characteristic conditions, especially with PYCR1 mutation causes cutis laxa type 2B, where the predominant symptoms are those of connective tissue, and the PYCR2 mutations lead to hypomyelinating leukodystrophy 10, where the predominant signs and symptoms are neurological. So a review of literature revealed that there have been 3 studies previously done in 2015, 2016, and 2017. In 2015, Nakayama et al., they described 4 patients from 2 consanguineous families with PYCR2 mutation-related microcephaly and hypomyelination. In 2016, Zaki et al. Expanded the clinical account of PYCR2-related disorders by presenting 14 patients from 11 consanguineous families with homozygous PYCR2 mutations. And in 2017, Meng et al. Added 5 more patients from 3 families with homozygous nonsense or missense variety of PYCR2 mutation. Coming to understanding the pathogenetic mechanism, Nakayama et al. In his study in 2015, they demonstrated in their study that PYCR2 deficient cells, they showed increased apoptosis under oxidative stress, and therefore postnatal microcephaly was likely due to increased cell death in the central nervous system. And also PYCR2 deficiency weakens mitochondrial membrane potentials, and the process of myelination, being an energy-dependent process, gets impaired, resulting in hypomyelination. The clinical presentation, as summarized by Jackie et al., showed that microcephaly, failure to thrive, intellectual disability, upper motor neuron type signs, then muscle atrophy and developmental delay were present in 100% of cases, while other symptoms were variable, like excessive vomiting, spasticity, nystagmus, and seizures were present in half of the patients. Also, in our child, seizures was not present. So characteristic facial findings are seen in children with PYCR2 mutation, and they have typical triangular facies associated with bulbous nasal tip, malar hypoplasia, and prominent low set ears, as you can see in the different pictures here. And next to it is the R case, also having similar characteristic facies. The MRI findings showed that hypomyelination, ventriculomegaly, cerebral atrophy, and thin corpus callosum was present in all these cases. So, as we know that hypomyelinating leukodystrophy, they are a group of progressive condition and they have very poor prognosis. In the study by Nakayama et al., they saw that the patients succumbed from failure to thrive and complications from pulmonary infections, and there were no living survivors beyond the age of 10 years. Treatment is mostly supportive and symptomatic. It requires a multidisciplinary team to address various issues like spasticity, feeding difficulties, constipation, mobility issues, nutritional deficiencies, etc. So with increasing awareness about the complex neurological disorders and most importantly, availability of genetic tests, not only to the big cities, but to smaller cities and towns, have made it possible for us to do a complete workup of complex neurological disorders. And with the help of genetic tests, a precise diagnosis is possible. as we know that accurate diagnosis helps in outlining the course of the disease, in providing treatment. As we know, it's time of precision medicine. Sometimes genetic diagnosis can help identify specific treatment in certain conditions, and also helps in prognosticating the parents. And most importantly, these tests help to plan future pregnancies so that parents can avoid such disorders in future babies. So with this, I come to the end of